Hello everyone, I'm Sara Willems. I come from Ghent University, Department of General Practice and Primary Healthcare. I'm actually new to many people of you. I'm recently, or past 2 years, I became more interested in the quality debate, and that was a purely at random fact, being I worked at the Department of Primary Healthcare. We have the Belgian delegate, or one of the Belgian delegates, also working there, and we met by accident. And he told me about quality of care, and I told him about equity, and then we thought, well, the two things should go together, so we decided to go together for a couple of things, but also to go together in research. And so the idea came to organize a workshop in Copenhagen on the EQuiP conference on equity as a quality dimension. And from the one thing came the other, and we were so happy when we got a mail from Hector telling us that the conference in Paris today would focus on equity. So I was asked by Hector and by the French people, the French colleagues, to tell you something about equity in care. What is equity in healthcare? We all know about equity in health, but what is equity in healthcare? So this is what I'm going to tell you in the next half an hour. I warn you, it will be quite theoretical. But then someone else will come and tell you very interesting stuff, and then I will come back and I'll have a second presentation, and I will tell you then about QualiCops, which is a huge European study that is actually running now in all European countries. You might have heard about it. And I will give you the primeur, the first results on equity in all these European countries. So that's the second talk I will have later this afternoon. Yes, please. Right, let's start with the good news. Life expectancy. I put down the numbers of Belgium. Life expectancy in Belgium increases. Every year we get newspaper articles telling us that we will all live longer. My daughter will live 8 years longer than I will, on average. Also in Europe, we see it in almost all European countries that life expectancy goes up. Yes. The problem is, it's not for all people in the same extent. Everyone enjoys this improvement. All social classes will enjoy this improvement of increasing health expectancy or life expectancy, but what we see is that your educational degree, for example, determines how much you will enjoy this improvement. And this gives numbers for people, men of 25 years old. I don't know, I don't think we have 25-year-old men here, but what you see is that a man with of 25, oh yes you are, you're the example, you're the example. You have a degree of higher education, which means that by average you will live another 54 years. The same boys that sat in school, in primary school with Ulrich, who didn't get a higher degree, will live less longer. And you see quite a difference between those social groups, yes. What is important is that this is not only a case for the highest educated versus the lowest educated. This is not only a problem for the poorest in our society, but what we see, and this is what this graph shows very well, what you see is that this goes in little steps. Every step you go down on the social ladder decreases your chance on longer life. Yes. I'm going to skip this one. It's too, it will take too much time. However, sometimes we see differences in health between social classes. The question is this a problem? And you might say, yes, this is a problem. And I will say, yes, this is sometimes a problem. Sometimes, in some cases, when you see differences in health between social classes, this is a societal problem. But not always, and I will go into this a bit further. Yes. Yeah. For example, if you see that you have two persons, one with a higher educational level, one with a lower educational level, the person with the lower educational level gets injured in a severe traffic injury because he is not wearing his seatbelt. Is this inequity in health? No, it's not an inequity. It's purely an individual choice you make there, which makes that you are more ill. If we look at sickle cell anemia, which is a very common disease in people with a black skin, you hardly see it in people with white skin. Is this health inequity? No, it's not health inequity. It is a genetic thing. It is very sad that people with black skin have this problem more often, but there's little that we can do about it. Yeah. Same with arthritis. We see arthritis much more in older people than in younger people. Is this a societal problem? No, it's also a sad story. It's very bad if you have this disease, but it's purely a matter of biological aging. So there's nothing or very little that we can do about it on societal level. Yeah. What we also see in the States is that black women delivering babies, their babies are usually lighter, have lower birth weights than white women who get babies. And this is a problem. This is a societal problem. Why? Because this is caused by societal mechanisms. This is caused by access to care. It is because these black women have lesser good care, have lesser access to good medical care than the white women. So it's these inequalities that we are talking about today, right? So just the boring stuff, the definition, there is a difference between health inequality and health inequity. Health inequality are differences in health status or in distribution of health between population groups. Yeah. Next one, please. For example, in these examples we looked at black people versus white people, older people versus younger people, all kinds of social groups within our society. Yeah. Sometimes these differences are caused by biological reasons or by free choice, wearing your seatbelt or not. And in that case, you can't say there is something ethically or ideologically unacceptable about it. It is unavoidable by society. Yes. Yeah. Next one. Next one. But what we also sometimes see is that some of the differences are caused by external indicators, external things that go on, societal processes that are going on. And therefore, this uneven distribution is unfair, is considered unfair. And this is something that is unjust, and we have to work on that. Yes, next one please. And in that case, in the case of the black women, you see it has to do with reduced access to care. Yeah. And in that case, we don't talk about health inequalities, we talk about health inequity. And this is what we are talking about. Yeah. Next one, please. So one of the questions that we are tackling here is, can the healthcare system tackle or contribute to inequity in healthcare? Yeah. Yeah, thank you. So the question, can the healthcare system contribute or tackle inequity in health? The answer is yes, and Barbara Starfield learned that. She did huge studies in the US about what primary care can do, and what she showed is that good primary care leads to better health outcomes, lower costs, and greater equity in health. Yeah. So next one, please. So the question is not, can the healthcare system tackle or contribute to equity in health, but the question is, how can the system tackle or contribute to health inequality or health inequity? And this is what I will try to focus on in the presentation in the next 20 minutes. The thing is, in order to contribute to health equity, your system should be equitable. Yes. The question is, what is an equitable healthcare system? Does it mean equal care for everyone? Does it mean that we have to check blood pressure of everyone in the same way, the same number of times? Do we have to do the same tests for everyone? Do we have to offer people the same prevention procedures? Or do we have to make differences in that? And the answer is no. We don't have to deliver the same care for everyone. We have to change the level of care and the type of care we offer to people, and it has to be in line with the need for care they have. So we have to defer what we deliver people in order to match the need for healthcare. And what is equal care? What do we mean by equal care? Traditionally in literature, when you try to find a solution or an answer on this question, traditionally in literature you see that equal care is considered as equal access for people in equal need, equal treatment for people in equal need, and equal outcomes for people in equal need. That is traditionally what we see, and this is the structure that I will be using in the next few slides, but it's also the structure or the theoretical basis that I will be using to present to you the QualiCops data later this afternoon. Okay. So if we see there are variations in the process of care, if we see that there are variations in the access to care, for people with the same need of care, then we have a problem. If we see that two pregnant women with the same background, etc., but one of them is black and the other one is white, if we see that they have different access to care, or they have access to different types of care, we have inequity in healthcare. And this is very essential. The question is, next one please. No. Previous one. Yeah. The question is, what about equity in healthcare? And I will present you the case of Belgium, because that's the one that I know best. Yeah. Let's take a look first at equal access to care in Belgium. Yeah. One of the questions you can ask yourself if you talk about access to care is the question whether we have financial barriers in access to care. Yeah. If you look in Belgium, yes, next one. If we look in Belgium, this looks like a very complicated table, but it's not. You look just at this. The last one here is the average cost per patient. What is the cost in Belgium per patient? You see that it's about 210 euros per patient per year. Yeah. But what you see here is that there's a huge difference. This is the average for Belgium, and this is the number for people without a chronic disease. This is the number for people with a chronic disease. What you see here is that people with chronic diseases have much higher costs for care than people without a chronic disease. Yeah, that's one. We have a national health survey that is held every 4 years. And in that survey we ask people, did you postpone healthcare in the last 12 months because of financial reasons? And these are very important numbers. What we see here, these are the provinces in Belgium. This is Flanders, the Walloon region, and this is for Belgium. What you see for Belgium is 13% of the Belgian people indicate that they postponed medical care in the last 12 months because of financial reasons. These are numbers from 2008. Probably this number will be higher in the current social situation, the current economic crisis. What is even more important is that when you look at the same numbers according to the educational level of the patients, what you see here is the lower patients' educational level, the higher their reporting of postponement of medical care because of financial reasons. What is also important is that even in the highest educational classes, we see people telling us that they postponed medical care because of financial reasons. One thing that has to do with access is the financial barriers. Another thing is geographical barriers. Do we have geographical barriers to healthcare? Yes. This is Belgium. Yeah. I just put France and Norway next to it. If you see the difference in distances, you can imagine that in Belgium geographical access is less a problem because we're such a very small country. I was in Canada, in Northern Ontario, a couple of months ago to give a presentation on access to care, and if you put Belgium there next to Ontario, it was like this. That's one province of Canada, and indeed if you were there, and I was there for quite a time, you see that geographical access is a real problem in states with large distances. In Belgium we don't have that problem so much, although there are some geographical problems. Anyway, another indicator that we sometimes use to evaluate the access to care or equity in access to care is the distribution of care providers. Do we see more care providers in regions with higher educated people, for example? Yeah. If you look at full-time equivalents of GPs in Belgium, we have quite a positive image, you see that the number of full-time equivalents of doctors in Belgium stays more or less the same. It's even increasing a bit. So we don't, if you look at this figure, you would say, there is not much a problem of workforce in Belgium, or in Belgium, yes, next one please. However, if you look at the distribution male-females, this is changing. I could only show you the numbers of 2009. We think that for 2008 it will be like this and lower and lower. So what we see is that the number of female doctors in Belgium is increasing. Yes. And going along with that, we know that more doctors are working part-time because female doctors usually work part-time in Belgium. What we also see is that our doctors are tending to go to cities, or what you can call a city in Belgium. So what we see is that although our full-time equivalents are staying the same or even increasing a bit, we notice already some regions in Flanders where there is a sort of shortage of GPs. Yes, next one. And one of the reasons this is caused, this is the age distribution. What we see is that our doctors are getting older, and it's the older doctors are the male doctors, and the younger doctors are the female doctors. So once the older doctors that are now in their 50s, once they will retire, they will be replaced most by women, which will work part-time. And we were on a holiday in one of the Kiegnom, which was in which province again? Limburg. People who know Belgium a bit. And we saw this flyer hanging in the windows in each house, and apparently there was a problem with finding a GP in Gingelom. Gingelom is the community, so it says wanted male or female doctor for Gingelom. So we have regions, we have little towns already in Flanders without a GP. Another way of looking at equity in healthcare is looking at treatment, and this is very important. This is something I would like to stress. When you look at a lot of literature saying something about access or about equity in healthcare, what strikes me there is that most of these publications, they talk about access to care. They equal access to care with equity in care, and that's not the case. I mean, equity in healthcare has to do with equity in access to care, but also with equity in treatment and outcomes, and this is something we tend to forget. I think one of the reasons is because equal access is easy to measure, or more or less easy to measure. Measuring whether all patients in your country or all people in your country get equal treatment or equal outcomes is something which is very difficult to measure. Equal treatment also has to do with doctor-patient communication. This is also something that we call treatment. It's not only about which medications people get, but also how are people treated. Yes, next one. And what we know is that good doctor-patient communication is associated with better health and better health outcomes. So a question that we had in our research group a couple of years ago was whether we see social variance in the doctor-patient communication according to the patient's social class. Do doctors communicate differently with patients from different socio-economic classes? So what we did was a systematic literature review, and we did it twice. We did it in 2005 and we did it in 2011. Both were published. The usual stuff you do when you do systematic reviews, we did. Yes, next one. We selected papers. 129 studies were found, we did some exclusion, etc., etc., and we ended up with 20 studies reporting on social differences in doctor-patient communication. So what did these 20 relevant papers told us in 2011? They told us that there is a variation in doctor-patient communication. Doctors change their communication style according to the social status of the patient. Sometimes this can be a good thing. It can be a good thing if you, as a doctor, explain more because your patient is someone with a lower educational level. So it might indicate something good. However, it showed the opposite. It showed us that doctors give less information to patients with lower educational backgrounds, involve them less frequently in treatment decisions. Doctors use a more directive consultation style, do less socio-emotional talk. Patients have lesser control in these consultations. So that was not really good news that we found. I just told you we did it twice. We did it 10 years ago, we did it now recently. And the question was, did we change? Did the reality change? What we learned from the two studies was that doctor-patient communication over the last years, it became much more an important topic. In the period 65-2002, we found 42 papers, and in the few years here, we found already 87 papers. So this is, on research level, something that's becoming very hot to study. A lot of people are studying this. What we also see is then that the more recent papers, there's more emphasis on the reciprocity of communication. So more papers are saying, well, maybe these doctors change their style, but this maybe has to do with what the patient wants. Can it be the patient who wants us to communicate different with them? So there's a growing interest in these papers, at least, in patients' perception. What do patients want? And is it possible that the patient from a lower socio-economic background wants something different from their communication with their doctor than someone from a higher education background? So what we did was, of course, set up a study now, looking at what do patients want. So in EQuiP, the study I will be talking about in a few minutes, in EQuiP we asked patients, what do you want in a doctor-patient communication? And do you want something else than your neighbor who has a higher educational level or who has a higher income? Another indicator to look at treatment is doctor's attitude. What is the doctor's attitude towards patients? Does this attitude is different? Do doctors look differently at patients from lower or from higher socioeconomic classes? What we did in Belgium there was a study with 11 GPs in Flanders. It's a qualitative study, so very low numbers, 11 doctors, but we talked for hours and hours with them, just to dig this attitude out, because this is something very difficult to find and to illustrate. Yeah, we analyzed it qualitatively, and what we saw was that some doctors say working with low SES patients can be very rewarding. Other doctors say this is the most tiring part of my job. So that was something strange. Some of them said one thing and the other ones said completely something different. Yeah, excellent. So the question is, what determines whether a doctor finds it rewarding or not rewarding? And what we saw there is that the choice or the feeling of the doctor has to do with the number of patients from low SES doctors have to treat. What we saw was that doctors with high numbers of low SES patients in their practice, they tend to go into this attitude that for them it's very, very tough. What we see is that doctors with very mixed population groups, very mixed patient groups, they seem to find it very rewarding to work with low SES patients. They can put a lot of time in it because it's only a limited number of patients. If you have to put a lot of time in all of your patients, you get burnout and you get overloaded with work. Yeah. And this was a very interesting finding, and we're trying to quantify it now. We set up a new study to test our hypothesis in large numbers. And the government in Belgium picked this up, and the government said, well, we might change our financing system in Belgium, and we might go and finance doctors with high numbers of low SES patients. This is something they are considering now. Yeah. Another thing is, what about the outcomes of care? What about the outcomes of primary care, depending on the socio-economic background of the patient? Next. Outcomes is difficult to measure. How can you explain if you give two people with completely the same people, but one of them low SES, the other one high SES. You give them equal access to care, you give them equal treatment. How can you have different outcomes in care? Mostly this has to do with revalidation. What we see is that patients which come out of the same operation, for example, but when you go into a social context, which is very difficult with a lot of children, as a single mom, etc., you revalidate much slower than patients with higher educational backgrounds or higher socio-economic classes. So this is something we have to take into consideration if we want to realize equity in healthcare. Yeah. So, equity in healthcare in Belgium, it's a mixed picture, you know. We have the impression that, if you look at literature, that Belgium scores very well, but if you look into details, you see that there might be some problems in equity in healthcare. The question is, how do Belgium functions in Europe? What about the other countries? Are they doing better or are they doing worse? Is Belgium in the best or is it in the worst? And do we see differences in equity in the healthcare system according to, for example, the payment system? Do we see better access to care in system with patient lists? Or do we see better equity in healthcare in systems with pay for performance? Or do we see worse equity in healthcare in systems with pay for performance? Yeah. So what is the case of Europe? And that is a story I will tell you in half an hour. And then I will tell you the story of Polycoms.